Good morning and welcome back again to Colby Sawyer College. This is going to be a challenge, I can tell. There's too many good things to talk about. Thank you. Good morning and welcome to our second panel this morning, Women, Health, and Healthcare. It's my pleasure to welcome you. My name is Susan Reeves. I'll be the moderator for your panel this morning. I'm the chair of Nursing and Public Health here at Colby Sawyer College, and I'm pleased to introduce our panel members for this session. To my immediate left, panelist Heather Farr Gunnell is going to speak to us about healthcare issues related to domestic and sexual violence. Heather is the program director for the Sexual Assault Nurse Examiner Program for the state of New Hampshire, and throughout New Hampshire, the Coalition Against Domestic and Sexual Violence. She previously served as a legal advocacy and outreach service director for a domestic violence program prevention center. Ms. Gunnell has her master's degree in public policy from the New England College. To her left, panelist Kristina Fjeld will address Who Are the Uninsured? Kristina serves as Deputy Director of the New Hampshire Area Health Center at the Dartmouth Institute for Health Policy and Clinical Practice. In these roles, Ms. Fields manages grants, budgets, and program development, grant writing, website development, and strategic planning, grant program and implementation. Ms. Fjeld is a graduate of the Masters in Public Health program at the Dartmouth Institute for Health Policy and Clinical Practice. And to her left, panelist Jennifer Frizzell will address challenges and opportunities in protecting women's health in the current political environment. As a senior policy advisor to Planned Parenthood of Northern New England, Ms. Frizzell believes access to comprehensive reproductive health and education is critical for healthy women, healthy families, and healthy communities. Previously, Jennifer served as the Director for Policy for the New Hampshire Senate and Staff Attorney and Public Policy Director for New Hampshire Legal Assistance. She earned her law degree from Franklin Pierce Law Center. Please welcome our panel this morning.
So I'm going to kick us off with a fun topic to discuss this morning. I'm always the most popular person in the room with these issues. As she said, I'm going to talk to you today about engaging the medical community to prevent, detect, and treat patients who come in with domestic violence and sexual assault histories. We're used to talking about this topic in an advocacy framework or a criminal justice system framework, but we don't often talk about it as a healthcare issue the way we should. I'm going to start you out with a few statistics to frame this issue for you a little bit. The National Violence Against Women Survey in the year 2000 reported that 1.5 million American women reported being victims of physical or sexual violence in 1 year. So we're looking at 1.5 million women a year in this country who are victims of this type of violence. Most of these women are being victimized multiple times throughout the year because it's their intimate partner who is victimizing them. So what that gives us is 5 million physical or sexual assaults against women in our country every year. That's a huge number of people who are being affected by this issue, and we don't talk about it as if it were that big of a number, especially not in the terms of healthcare. We will talk about the flu, which is important, but we don't talk about domestic and sexual violence on that scope. In 2007, the New Hampshire Coalition also did a study, and what we found was that 33.4% of New Hampshire women reported that they had been victimized by their intimate partner within a year. So that's a third of the women in our state and across the country that are affected by this. The United States Surgeon General has said that domestic violence is one of the major health problems facing our country today. And the CDC, the Center for Disease Control and Prevention, says that domestic and sexual violence will create health problems that last a lifetime. So what we're looking at here is not just a one-time incident with an injury that heals and we're done. We're looking at chronic health problems that will last the scope of a lifetime and affect these victims throughout their life, which will affect the way they can work, the way they can care for their families, the way they can live in our society. The CDC also reported that every year we're looking at 1,200 deaths that are related to domestic violence and sexual assault. So we have 1,200 women every year dying in this country because of this abuse, and over 2 million injuries that are related to this. And these are just the ones we know about. So we have 2 million women in this country every year who are being treated for injuries related to domestic violence and sexual assault. But as we saw earlier with the national study, we know that there are over 5 million assaults happening every year. So we're not even seeing the number of patients that need treatment for what's happening to them. So let's talk a little bit about what are some of the health effects that people suffer when they are victimized by their partners. It's more than just acute physical injury. So we do have that quite often. There are times that we'll see that, but we know statistically that sexual assault victims, it's rare to find physical injury in these cases. But there is a dramatic amount of health effects that we have. So we have chronic pain. The victims will have chronic pain throughout their lives often. A number of gastrointestinal disorders are related to this type of abuse. When you think about what stress in your life can cause, when you're looking at headaches and migraines and digestive issues, think about the type of stress that comes with being in a relationship where you're being terrorized and victimized. Think about the level of stress that comes when you are sexually assaulted. And we know that most sexual assaults are by someone we know. They're by a partner or an acquaintance or a family member. So that elevates the level of stress. So all of the health issues that we see when we're stressed out are amplified for the victims of these crimes. We also see a number of psychosomatic disorders. There's a lot of psychological issues and mental health effects that come up. A number of eating disorders. Abuse has been linked to anorexia, bulimia, and obesity. So eating disorders are a really big outcome of people who are affected by abuse. PTSD is a really huge issue. There were studies done in the United States and in France, and those studies showed that between 50% and 95% of sexual assault victims had PTSD as a direct relation to the assault. So when we talk about PTSD and how it affects our service members, and we know just how difficult that can be to live with, we need to translate that and recognize that the people, the women in our country who are being sexually assaulted and victimized by their intimate partners are also suffering from those same PTSD symptoms. And we need to be able to address that and treat that. There's also a higher rate of depression and a much higher rate of being infected with a sexually transmitted disease or HIV and AIDS. One of the things we know about abuse victims is that their access to care is vastly limited by their abusive partner. So they are less able to choose what type of protection is used, if any at all. The partner controls that. They're at a much higher risk of becoming pregnant when they didn't want to be. It's fairly common for abusive partners to flush medications or not allow the victim to have medication. Victims of sexual assault, clearly when you're being sexually assaulted, you don't get a say in whether or not your assailant uses protection or not. And so victims are at a much higher rate of getting STDs and being infected with HIV. One of the other health effects that we don't talk about as often is strangulation. New Hampshire just passed a law, I think it was about a year ago, that made strangulation a felony. And we look at that in a criminal justice frame, but the reality of strangulation is that it may not leave any marks at all, but it can kill you within 36 hours. It only takes a couple of seconds of pressure to be able to close off someone's windpipe, and the damage from that can't be seen, but it can kill you. And so we need to start paying attention to that when we're seeing patients, primarily in the emergency department, but recognizing that it's not just a criminal offense, but it's a very significant health issue that people are faced with. There's also a much higher rate of substance abuse and tobacco use with women who have been victimized. So what we often see is we see women who are victims of sexual assault and domestic violence self-medicating because they have no other option. They don't know another way to cope. So we look at these women and we see that they're addicted to painkillers or that they are drinking, and we immediately start to look at them through a lens of being an addict, when it's quite possible that that's the only coping mechanism they have, and that the reason for that substance abuse is because they're not getting the help that they need. And we know that substance abuse is a health issue. We know that this affects people's health. And so if we start to look at the correlation between these health concerns and abuse, we can look at how we can start to prevent this and look at it better. Pregnancy, women who are pregnant and being abused are at a much higher risk of being killed and suffering from a number of issues. And they're much less likely to start getting prenatal care when they're supposed to. So that increases the risk of the pregnancy and the baby. So what do we do about this? I would argue that what we need to do is frame this as a healthcare issue, because that's what it is. We're really good at engaging the criminal justice system. We're really good at engaging the advocacy systems, and those are important systems. But I would argue that the healthcare system needs to be as engaged in this issue as it is in other issues. So we need to make it a requirement that medical professionals properly screen all of their patients every time they see them. We do it with other healthcare concerns. We should be doing it with this one. We need to go after a public awareness initiative in the same way we do with other healthcare concerns. We're really good at doing it this time every year with the flu, and we should be doing it for domestic violence and sexual assault. There's very few systems that are as good at public awareness as the medical world is, and we need to be tapping into that. And we need to look at this issue beyond the criminal justice system. We need to look at it through the lens of healthcare, because the number of victims who come into the criminal justice system are small, but the number of victims that come into the medical system are enormous. And so we need to reframe the way we look at this. Thank you.
Can you hear me? I have a bit of a cold, so I'm a little hoarse. Thank you for having me here today. This is pretty exciting. So I'm here to talk about the uninsured. And my position is, so long as we have a nation that we've chosen to use health insurance as a model to pay for health care, we should all have health insurance. Increasing access to comprehensive health insurance can improve the health of the population while at the same time contributing to the cost containment within the healthcare system. So today I'd like to talk about, I'm going to set the stage for Jennifer, my colleague here, and bring you up to speed on why we have uninsured right now and why the need for the healthcare reform. So I'm going to bring you up to March of 2010, when President Obama signed the Health Reform Act, or the Accountable Care Act, Affordable Care Act. Excuse me, I'm a little nervous. So right now we have 12%, or the number is actually pretty fluid. It grows and it changes every day. We have about 12% of the population in New Hampshire are without health insurance. On the national level, there's about 17%. Again, it's a number that changes daily. So about 17% of our population is without health insurance. So again, I'm going to walk through why we have health insurance, the types of health insurance, and why we have uninsured. So health insurance linking to employment, which is the model that we have today, dates back 130 years. It goes back to the mining and the railroad industry, where it's not the model that we have right now, but it does date back 130 years, where these companies hired doctors to be on staff to take care of their employees. Then in 1910, Montgomery Ward, they changed the model a little bit, where they had a health insurance product for their employees, but this wasn't to pay for health care. It was to ensure that folks who got sick still received their payment for their salary. However, the model that we have today was modeled after, or changed, morphed over time from 1940, when soldiers returned from World War II. During that time, we had a wage freeze, and for companies to attract skilled workforce, they offered this benefit to allow their employees to pay for their medical care. So this health insurance linking to employment dates back to 1940. However, when you have a model such as that, it creates gaps. So over time, we see that healthcare is changing. We have this incredible healthcare system. It's growing. We're saving lives, innovation within the healthcare system, but that drives up cost. So that with the cost going up, it's more important that we have health insurance to help us protect against financial loss. So in 1940, we have this health insurance model to cover the cost of healthcare. But those folks that aren't working then don't have health insurance. So in 1965, the federal government looked at who is without health insurance or access to health care. And those folks were the poor and the elderly, because they weren't working. So the federal government created Medicaid and Medicare. Medicaid is a program that's funded by the state and federal government. The states put up money, and they're able to draw down the federal matching dollars. Medicaid is administered by the states. In New Hampshire, right now, the Medicaid program covers pregnant women up to 85% of the federal poverty level. And I've included these pages on your table to understand what the federal poverty level is and the percentage of the federal poverty level for families. So the family size is down the side, and the percentage of the federal poverty level is in columns. So pregnant women are eligible for Medicaid up to 185% of the federal poverty level. Infants are eligible in families up to 300% of the federal poverty level. And parents, non-working parents, are eligible at 48% of the federal poverty level, and working parents, 60% of the federal poverty level. It's also for other populations, the medical needy, SSI, et cetera. Now, Medicare was also established in 1965, and that was for the elderly population. As the first panel I talked about Social Security, we pay into the Medicare Trust Fund through the FICA tax. So we all have a trust fund. So we've all been paying into this trust fund. And both these programs are entitlements, so which means that the Medicare, you have to pay in for a certain number of quarters in order to be eligible to receive it. But Medicaid is an entitlement, which means that if you are eligible, if you meet the eligibility criteria, you should receive that service, or you are eligible to receive that service. So now we've covered the poorest and also the elderly. So we have employment-based health insurance, and we have coverage for the poorest and the elderly. So time goes on, and we recognize there's still gaps in coverage. There's still gaps in access to health care in our country. So healthcare continues, innovation in healthcare. We are saving lives, people are living longer, and the costs keep going up. But a lot of people don't have access. So in 1997, during the Clinton administration, it was recognized that there were 10 million children of working families who did not have access to health insurance. And at that time, we passed the state children's health insurance program, which increased the eligibility for these families. So the states, it's similar to Medicaid, where it's administered by the state, and it's for working families who had modest incomes but made too much money to qualify for Medicaid. So it picked up where Medicaid left off. So some states went up to 200% of the federal poverty level. Some states went a little bit higher, but they were able to decide what they wanted to do with their state children's health insurance program. And that covered children up through the age of 18. So we've now covered the cohort of people in our country with some type of health insurance product. The poorest, children up to the age of 18, and the elderly. But there's this group in the middle between 19 and 64 who are working Americans who don't have access to health insurance. And the reason is because health insurance, a group health insurance product, which differs from an individual product, group health insurance products offer more protection. They often don't drop you if you get sick, where an individual product does. So this group health insurance product, I just have some statistics. So the employment-based insurance. So now I'm gonna go into who is uninsured. So I'm looking at I have 2 minutes. Oh my goodness. Okay, I'm gonna go fast. 62% of non-elderly Americans receive employment-based health insurance. 17% are on government insurance, but the rate is dropping. So 84% of large employers in the state of New Hampshire offer health insurance to their full-time employees. Yet 16% of large employers offer benefits to their part-time employees. 58% of small employers offer health insurance benefits to their full-time employees, yet 8% offer to their part-time employees. And under the Health Insurance Portability Act, it allowed HIPAA, which we all go to the doctors and sign, it's a privacy. It allowed companies to offer health insurance benefits to similar situated employees without discrimination. So it allowed them to say, you can offer benefits to all full-time employees, but you don't have to offer it to part-time employees. So with that whole mechanism created, we now have this group of working Americans who work for primarily small employers, are self-employers, or work part-time or multiple part-time jobs who are without health insurance benefits. So I only have 1 minute, but I want to talk quickly about why it's important to have health insurance. Research shows that the uninsured receive less medical care, less timely care, and have worse health outcomes. Someone without insurance seeks care at a later stage in disease. They require more interventions, have more costly and invasive procedures, and have worse outcomes. The Institute of Medicine conducted a series of studies looking at the consequence of the uninsured, and and it's well documented that the uninsured adults have worse health outcomes comparing to the adults that have health insurance. And so it's a quality of life issue. And the costs, I'm out of time now, but I'm going to quickly talk about costs. So individually, poor health outcomes. 50% of bankruptcies in the United States are a result of health care bills. And it's a strain on the family. If somebody is sick, if somebody has pneumonia as opposed to getting antibiotics at an early stage, it's a strain on a family. It's also a strain on society when we have a less productive workforce because they're not healthy. And it's a strain on the healthcare system. In 2007, $600 million from the hospitals in New Hampshire had to absorb as a result of charity care and uncompensated care. And there's a whole cost-shifting mechanism, which I've run out of time and I can't talk about. but I'm going to now hand it off to Jennifer.
Thanks, Kristen, and to the group, and thank you to the Caucus committee for inviting me to be here today. What I'd like to do is talk about why it's critical for women to have access to comprehensive health care for healthy families and healthy communities, and to highlight within that position the need for reproductive and sexual health services in a comprehensive nature to be included as basic primary care for women, and for those of you who care about protecting those services, to understand the very real and imminent political and policy threats that those types of services are facing in the current environment. In my work currently with Planned Parenthood of Northern New England, I have the opportunity to see an issue like this through both the lens of the provider, because Planned Parenthood in our country, in all 50 states, and here in New Hampshire as well, is the largest provider of reproductive health services to women. Here in New Hampshire, we see over 16,000 patients each year through 6 health centers. And so as a provider, we're able to see how women are utilizing health care to meet their primary and reproductive needs, what access barriers they face, and in what ways our healthcare system is designed to either encourage or discourage the use of care or the healthy outcomes that come from care. But Planned Parenthood historically has also been a real player in the advocacy arena, protecting and trying to preserve and expand an array of women's health services. And so we bring to this conversation really the experience and the expertise of our healthcare providers, seeing what women need every day, and our role as a trusted, non-judgmental provider gives us a really powerful and influential opportunity to work with medical community, to work with elected officials, and to try to bring to their attention the very real needs and values of women's healthcare services. In the current environment, we have both opportunities and challenges. And the Affordable Care Act, also known as federal health reform, that passed in 2010 in the US Congress, really disproportionately presents opportunities to create some equity and some balance for women in healthcare access. We know through those who come through the doors at Planned Parenthood, 70% of our patients in New Hampshire are uninsured and under 150% of the poverty level. And many of those are women in their young childbearing years who have not attached to the labor market to have access to full-time jobs. They may be in an education phase of their life where they're coming in and out of school and part-time work. And we know that that's a population where when we invest in preventative and primary care, we see a lifetime of gains for that population. And so a program like the Affordable Care Act that creates on-ramps for women to have access to primary care and to not have to use it in an episodic way, like through community health centers or only when they're coming through the emergency room door, reaps wonderful benefits, not only for their individual health needs, but also for ultimately the costs of health care, because we know that investing in prevention, which is, well women gynecological exams, cancer screenings and disease prevention, and access to family planning and birth control. These are some of the most cost-effective investments we can make in the healthcare system to not only help contain costs in the system, but also to help contain downstream costs for other social programs and other family stress that comes when women don't have access to the family planning and health care to keep themselves healthy and to plan their family size. And the Affordable Care Act and its provisions to cover women provide some real opportunities and on-ramps to balance the historic gender discrimination in access to health care and in access to health insurance. The law itself prohibits gender discrimination in pricing of insurance. It ensures that a variety of women's preventative services and wellness services must be provided as part of primary care without copays. And many of you may be aware of some directives from the U.S. Secretary of Health and Human Services, Kathleen Sebelius, earlier this year, that services that have caused women to have disproportionate amount of copays over the years, like copays for birth control or copays for other mammograms, are now services that need to be provided without copays or deductibles as part of the health care safety net. So there are real benefits included in that as well. My colleague on the panel talked about the importance of domestic violence screening for women. One of those directives as part of health care is that providers will need to reimburse for the cost for medical professionals to undertake the time to provide that kind of training for women. And it will have to be done in a way where there isn't extra cost to the patient or the victim herself under those circumstances. So there are many layers of the policies of the Affordable Care Act that begin to equalize the role that women's health services have in the design of insurance plans, in the delivery of services, and ultimately in the cost trajectory of where we're able to invest in giving women access to preventative care. And I think really women play a particular role in whether the Affordable Care Act will make it across the finish line with regard to its implementation. There are so many specific benefits in the Affordable Care Act for women and for uninsured women who are now getting episodic and not primary care, that through dialogues and discussions like the caucus here today, it's really important for us to make sure that women's voices are heard in the public arena, as there are so many threats to erode and repeal the components of federal health reform that will so greatly benefit women and bring some reason to our system with regard to everybody being included in the insurance pool. Now, I want to save some time to specifically talk about threats in the current environment to reproductive care. Clearly, Planned Parenthood has played a historic role in both delivering comprehensive reproductive health care. Preventative care is 97% of the work that we do at Planned Parenthood. But we also believe deeply that abortion care is a critical part of women's comprehensive reproductive care. And so we're constantly in the public arena, in the public debate, defending and advocating for access to services without barriers and without threats. And the year that we've endured since the 2010 elections, both at the national level and here at the state of New Hampshire level, really tops none, at least in the last few decades, with regard to the scope and the national reach of those who have an agenda, and that they've really leapfrogged over abortion as the contentious issue in these debates to have more sweeping and extreme proposals that would completely defund or completely eliminate the existence of programs that provide women with access to birth control, with access to cancer screenings. The broad women's health program that has provided primary care for women, including reproductive health care at the national level, the Title X program, is at risk in this very, in the current congressional environment and probably in the next presidential election. There have been many pledges by candidates to eliminate that program and or to specifically defund organizations like Planned Parenthood that serve a primary role in delivering those services and a primary role in speaking truth about the need for those services. And here in New Hampshire, we've had our own narrative on the national stage. Many of you may remember back in March, as incredulous as it may seem, the entire federal government almost shut down over an attempt by the U.S. House to only move forward and negotiate with the President and the Senate on a continuing resolution if defunding Planned Parenthood was the critical priority that they could gain in that negotiation. Now, an organization like Planned Parenthood has seen or touched 1 in 4 American women who have come through our door. So we have had an incredibly effective year at bringing voices and bringing people with direct experience with reproductive health care into the public debate, out onto the streets where necessary for either rallies or protests. And it's that kind of engagement from women who have experience and want to protect reproductive health services that allowed the Planned Parenthood and women's health community at the national level to push back on those issues. And we really know that most women think that their health care should not be a partisan issue, nor should it be a political issue. And when they can make a connection to elected officials who want to take away their pap smears, who want to take away their access to basic birth control, it does really create an opportunity for somebody to have a personal reason to get political. And I think it's one of the things that makes Planned Parenthood a very unique messenger in the public debate, is that we have earned the trust of so many women and families as a provider of services. We have had a regular presence in the community dialogue about the need for these services. And ultimately, when we are able to come out and connect the needs of our patients to the needs of good policy, we think that it provides an opportunity for more women to pay attention and to carry the message of how important these services are. So I would ask you to think about the importance of ensuring in who you're watching, who's in elected office, or who you're watching who might be seeking your vote for future elected office. Women will play such a tremendous role in deciding the 2012 elections from the top of the ticket down, that carrying issues like comprehensive women's health care into the other aspects of your civic life are both compelling and important for our community. Thank you.
Thank you all. Would now like to open up the opportunity for you all to ask questions of the panelists. I understand we have roving microphones, and there's a hand up right down here. Thank you. Would you please introduce yourself and let us know which panelist you'd like to address your question? Thank you.
Certainly. My name's Erin Klein, and I have a question for Kristina. You had discussed state programs that are already in place for people in low-income backgrounds and people with modest incomes for their children. But right now, those patients in many cases still have trouble being seen because the insurance isn't necessarily good insurance, and doctors see so little return on what they bill. And I know in many cases, rather than having a child be in to see a specialist when they need to, doctors will advocate that they go to the ER because it'll be 3 months before you're seen for something as simple as a broken leg. What sort of suggestions do you have to make changes in that sense? Or for, I guess, for before we take action in getting insurance for the 19 to 64 population, what can we do to see our programs that we already have?
Well, I think this goes to the cost containment within the healthcare system, and it's a big issue that you're asking about. So when we have, there's many reasons why the costs are the way they are, and why doctors are sometimes having to turn away patients due to the reimbursement. So the reimbursement for some types of healthcare, government-funded healthcare, are lower than the reimbursements for private payers. And this is what I was going to talk about. There's this cost-shifting mechanism that occurs in healthcare where the government, so we have uninsured, and somehow the hospital has to absorb the costs to cover the uninsured. And what they do is they shift the costs to private payers. So $1 in $4 for a private payer covers the cost of the uninsured. So the costs then it's interesting, when you look at the costs within the healthcare system, it's really hard to calculate exactly what the costs of some of the services are. So with that mechanism, the government decides how much they're going to pay for a procedure. But when the hospitals are then transferring the costs to cover the uninsured and uncompensated care to private payers, they're saying that, say, a hip replacement costs $10,000, and I have no idea how much a hip replacement costs, but I'm just going to say that. So the government will say, we are going to pay $10,000 for hip replacement. But over time, when the hospitals are then transferring the cost from private payers to cover the cost of the uninsured, they have to then say they're going to charge private payers $20,000 for this hip procedure. But the government payers are saying we're paying $10,000. So there appears to be a gap in what the services cost. So at times, some doctors are now not able to, because of the funding, take some of the government payers. So I think that what would change the cost structure within the healthcare system is if we all had coverage. That gap wouldn't be quite so great.
Thank you. I just wanted to, my
Would you
name is
introduce-
Susan
thank you.
DeMoore. I work for the Concord Feminist Health Center in Concord. We've been a healthcare facility primarily serving women, primarily uninsured, since 1974. Thank you. And I applaud the efforts of Planned Parenthood. But I want to just mention that in the role of access to things like pap smears and non-copays for gynecological services and things like that, most insurance companies have made it a requirement that the practitioner that client see has very specific credentials. So you can't say go to your nurse practitioner, who perhaps is your first choice of healthcare provider, and if she is not certified in women's health, then you will not have your pap smear paid for. So I would encourage all of you that are writing to your politicians to say that health care for women should be covered without copays, but that it shouldn't be necessarily dependent on their licensure. I don't think a chiropractor should be reimbursed for giving a pap smear, but I think that a nurse practitioner, a family health care physician should not be excluded from treating women and not having to charge them a copay. And I also just want to remind everyone that while Planned Parenthood does absolutely do a phenomenal amount of work around the world, or around the United States, there are many nonprofit facilities that really depend on your support and your interest. And when you have are talking with people that are uninsured or that are looking for affordable access to health care, there are alternatives to places like Planned Parenthood, which I'm not saying, I don't want to discount your efforts, but that there are other places in the state that are supportive and affordable and want women to know that we are a safe choice for them to come if there's a domestic violence issue, and that, that there are other places to go, and we really need the laws to change so that pap smears can be covered by qualified nurse practitioners, qualified family physicians.
Thank you.
That abortions can be covered, if that's the choice you want to make, by somebody that is not an OBGYN, but is
Thank you
qualified.
very much.
Do anybody care to respond?
No, okay. Another question, please.
Hi, I'm Xantha Hilton. This is a question for Heather, and I was just wondering, in the criminal justice system, we use this idea that they're an alleged victim of sexual violence, and in the healthcare system, it's clear when someone is a victim. How do we bridge that gap between the healthcare system and the criminal justice system?
That's a really good question, but I'm not sure the gap needs to be bridged, and let me explain that a little bit, because the criminal justice system has a very specific role where they have to refer to the victim as an alleged victim, as damaging as that can be to someone who is referred to that way. Their role is to figure out what happened and to address that criminally. However, in the healthcare system, it's not our role to say alleged or guess. When someone comes in and talks to their doctor and says, I hit a tree with my car and I have a broken leg, we don't say they allegedly hit the tree with their car and allegedly have a broken leg, right? So why would we do that with domestic violence or sexual assault patients? No, if someone comes in and tells their doctor or reports to the hospital, I was just sexually assaulted, there's no excuse for a medical provider to say allegedly. And so we need to be clear with that. The criminal justice system has a particular role, but the medical system is not bound by that. And we need to address all patients in the same way with that same objectivity.
Thank you. Could you stand so that folks with the microphone can see you? Yeah, thank you.
Thank you, Jackie Silly. You talked about coverage and the extent of the coverage, but there are two things going on, at least in the New Hampshire legislature, that are, in my estimation, particularly dangerous because it speaks to what is covered. It's the components of what insurance means. So there is a bill that everybody in this room should be familiar with, and I'd love for the panel to speak about it, that will remove the responsibility of insurance providers to cover midwives, to cover autism, to cover hearing aids, to cover, there's a whole list of things that they are stripping out. While Democrats were in the majority, we also extended coverage to divorced spouses as long as they hadn't remarried. So all of that is being stripped out. And that's in one bill. The second bill will allow New Hampshire citizens to buy a policy from Alabama, from Mississippi. You can already do that, by the way, except that policy has to meet the standards of a New Hampshire provider. The way they're writing this one will, so if Mississippi says, you get your basic physical and two other things, that's what you'll be buying. And so it isn't just being covered, I suspect, it's also what that covers and the economic benefits of that. So I don't know if you want to speak to it, but that's all going through starting in January.
It's a great point. We had limited time, so I was trying to brush broad strokes, but I don't have much to add to that. Also in New Hampshire, so there's a difference between a group product and an individual product, and the coverage is the difference. I mean, there's many differences between the two products. In New Hampshire also, we have, New Hampshire's beyond many states in coverage. In New Hampshire, we also have access for small employers to set up a premium-only Section 125 account, which allows employees to purchase their own group of one health insurance product pre-taxed. So it allows a cost savings as well by doing it pre-tax than they would have to purchase if their employer didn't offer health insurance on the individual market. But I appreciate your comments. Do you have anything?
Yeah, I guess I would just comment and say that there is a dynamic with federal health reform where the state used to be able to be the primary regulator with regard to what a minimum health insurance package needs to include, what are the kinds of services that make the package kind of either balanced enough or free of discriminatory practices. And it's taken some policy making over the years to ensure that some services that health plans may try to either offload the cost to the consumer or the insured themselves, or maybe think they're services that should be picked up by a school district, not necessarily a health provider. There clearly has been a lot of work done over the years in New Hampshire to build a minimum health package that is at risk with some of these repeals that were just mentioned. And, disproportionately, the midwife issue being a prime example, it's often the unique ways that women access health care, the unique services that women need that somehow aren't part of the more patriarchal model of how insurance was originally created that are the first to be on the list to be repealed. I will say that there is an expectation that the Secretary of HHS on a federal level will design a minimum a minimum benefit package that will have to be the floor at each state level, and then the state will be able to add on to that through its health exchange in a future health reform world. And it may be that advocacy that's not working right now at the state level needs to be redirected at the federal level while there's an opportunity.
I think one of the other things I heard our questioner saying is how critically important it is that we know what's going on right here in our own state, that oftentimes such provisions are buried inside what can often look like very innocuous bills. But if you really look deeply at what's being proposed, you'll find the kinds of things that you're mentioning. So us being aware of these things is very important. Lots of questions. Where are our microphones?
Thank you. Hi, my name is Sue McKevitt. I'd like to make a comment, and I'd like to shift the conversation from health insurance to health care. I think there's a big difference, and I think as long as we stay in the house of health insurance and talk about what deductibles and who's allowed to do what, we're missing the boat. That's my comment.
Thank you very much.
I also have a question. At one point, our table was talking about the issues that we're hearing today. In the 60s, when I was a little bit more feisty, these are the issues that we were dealing with. In the 40s, when my mom was still around and she was feisty, these were the issues she was dealing with. When Emma Goldman was feisty, back at the turn of the century, the last one, these were the issues that she was fighting with. I'm wondering, in this persistent environment of disregarding and disparaging and really hating women, what strategies might we employ that can move the agenda so that we don't have to keep repeating the same issues?
I think.
Okay. Please, no, please.
I guess I'll say two things. I think that the program today is built around a series of tactical skills this afternoon. So if you were tempted to leave at lunch, stay and make sure to get the perspectives of several current and former elected officials who I think have a lot of experience and a lot of ideas around that. I mean, I think I'd say number one, good for everybody who's here today, because you took a step to educate yourself and engage yourself a little more in something that's obviously important to you. And if I understand at all the motives of the conveners today, it wasn't that the journey would end when the workshop ends today, but that it would be that you would feel empowered, or that you will have felt like you found a particular issue or a particular talent that you want to take beyond here. I mean, around specific skills or specific tactics, I'll say, and as I identified with some of my other panelists, one of the things that we do at Planned Parenthood, and we do it in coalition with others, is we also have a 501c4, which is not our healthcare delivery arm, but is our issue advocacy arm, where we try to do everything from educate constituencies about what's going on around access to healthcare, to recruiting people to run for office. It's so critically important that if you're frustrated with the people that we have running our community and state level governments, that you think about offering yourself or someone you can recruit as a substitute, because there are so many of the opportunities with such a large house in New Hampshire where not every seat is filled with somebody who comes looking to protect or advance issues that are important to women.
Thank you.
So we certainly need your talent and your energy in that regard.
Thank you.
Jennifer, that was very understated.
Okay, a question here?
Oh. Thank you, Susan. Judy Joy, and I have been working very long with the New Hampshire Nurses Association, a very large organization of women in New Hampshire, women and men in New Hampshire. And we have reached out recently, and the comments that have just been made are a really perfect segue. We've been reaching out to a lot of organizations, including the Nurse Practitioner Organization, to work together on a lot of these issues. And Planned Parenthood and some of the other concerns that you've raised often touch sensitive topics. And we've had pushback from organizations, from people that we've reached out to that we would like to collaborate with. We've had pushback because there's a possibility in our polarized society today, there's a possibility that that we would disagree on some issue. And I hope that we'll hear this afternoon, and maybe you can comment on how we can get over this. We may disagree on something, so we can't get together, because that's what's keeping us as women, as nurses, and as a civil society, not just women, but as a civil society in moving forward. So, can you comment?
We have time for one last question. Did you want to speak? Please go ahead.
I just wanted to say, in my field, we're really used to having pushback. And one of the keys to it is you have to be tenacious, which we all know. But two, sometimes you have to look at, okay, what is my issue and what is my goal? And how do I frame that and explain it in a way that will touch this group I'm working with? So that's going to look different for all of us, and it's going to look different based on who you're trying to connect with. But sometimes we have to take the onus and say, okay, this is my issue, and I see the whole picture. So what part of that picture does this person need to see to work with me? And so we need to take responsibility for doing that.
Our time is at an end for this panel. Would you all join me in thanking our panelists for today? I'm sure they'll be available to you to speak with during the break. We'll now break for 10 minutes. Thank you.